Thyroid disorders. To understand thyroid disorders, we need to see what type of disorders there can be. Okay, there can be either hypothyroidism, which is due to decreased thyroxine levels basically, or hyperthyroidism, which may be due to increased thyroxine hormone levels. This is just a broad outlook. Okay, now before going into detail about this, let us know how thyroid gland works and how this thyroxine hormone production is controlled. Okay, so as you know, there is a pituitary gland which is divided into anterior and posterior pituitary. Okay, our main area of focus here is the anterior pituitary, which releases the TSH hormone. Okay, anterior pituitary releases the TSH hormone, that is thyroid stimulating hormone. This thyroid stimulating hormone acts on the thyroid gland, and thus the thyroid gland produces T3 and T4 hormones. Okay, thyroid stimulating hormone acts on the thyroid gland, okay, and produces T3 and T4 hormones. Okay, let's go a bit deep into this concept. The thyroid gland is made up of follicles. Okay, imagine a thyroid gland, its anatomy, it's made up of follicles. Okay, so when you see a thyroid follicle, on the outer aspect you can see a TSH receptor. On the outer aspect of a follicle, thyroid follicle, there is a TSH receptor to which our TSH binds. Okay, on the TSH receptor, the TSH binds, and this results in the production of T3 and T4 in the follicle. Okay, so whatever T3 and T4 is being produced, it won't keep quiet. Okay, it will send inhibitory signals to the anterior pituitary to stop producing the TSH. Okay, this is the negative feedback mechanism. So what happens whenever TSH has been sent by the pituitary, acts on the TSH receptors, forms T3 and T4. If excess amount of T3 and T4 are formed, this T3 T4 tells the pituitary to stop sending TSH. Okay, so that the TSH won't stimulate the thyroid gland to produce more T3 and T4. So this is a negative feedback mechanism. So this was basic physiology of thyroid gland and the hormones. Now let's start with the disorders of the thyroid gland. So generally, whenever we are talking about a gland, we will end up having two types of disorders. Okay, it may be either hypo or hyper. So for this purpose, let me tell you a basic classification of thyroid disorders. Okay, where we can have hypothyroidism, hyperthyroidism, and also we can have primary and secondary hypo or hyperthyroidism. Okay, what does this mean? This means that whenever there is a primary disorder, okay, primary disorder of the gland, okay, the problem is inside the gland itself. Whenever we say primary hypothyroidism or hyperthyroidism, that means the problem is within the gland itself. That is, there is malfunctioning of the gland. And whenever there is a secondary disorder such as secondary hypothyroidism or secondary hyperthyroidism, it means that it is secondary to some other disease. The problem is not in the gland, it is secondary to some other disease. For example, if I say secondary hypothyroidism, it may mean that the pituitary gland of the patient is not able to form TSH adequately. Okay, when I say secondary hypothyroidism, the pituitary gland is the area of problem. Okay, where TSH is not formed adequately, and the thyroid gland is not sensitized by the TSH properly, resulting in decreased T3 and T4. Now, in the following table, let's see each of the following scenarios. In primary hypothyroidism, what happens is the TSH levels are absolutely fine. Okay, because there is no defect in the pituitary gland. It's a primary disorder, there is no defect in the pituitary gland, so the TSH levels are normal. But it's not actually the case. Okay, just because the thyroid gland is not normal, it sends signals to the brain saying that the body doesn't have thyroid hormone. Okay, here the thyroid gland is not normal, right? So the thyroid gland sends signal to the brain saying that I don't have enough of thyroxine hormone, so send more of TSH. Okay, so send more of TSH so as to compensate for the decreased thyroid hormones. Here, remember one thing, even if the TSH is high, in this case, the thyroid sends signal to the brain. Okay, so the brain starts sending more and more TSH. So even if the TSH is high here, the T3 and T4 levels are low. Okay, in primary hypothyroidism, the TSH levels are high, the T3 and T4 levels are low. Why? Because the thyroid gland itself is defective. There are no T3 and T4 at the start. Okay, so whatever T3 and T4 are formed by the TSH come back to the normal level. Okay, so thus there is a primary hypothyroidism. Okay, let's talk about primary hyperthyroidism. As we know, in primary hyperthyroidism, in a primary kind of disorder, the defect lies in the gland. So for that case here, there is increased production of T3 and T4. There is increased production of T3 and T4 by the gland. Okay, because the gland is defective, it is primary hyperthyroidism. There is increased production of T3 and T4. The point to be noted here is that the gland produces increased T3 and T4 irrespective of the TSH level. It doesn't depend on the TSH, it just produces increased level of T3 and T4. So what happens if there is more T3 and T4? We just now discussed, right? Whenever there is increased T3 or T4, the gland asks the pituitary to stop sending TSH so that the gland won't get stimulated and more T3 and T4 are not released. Okay. So the TSH production is stopped. Hence, in primary hyperthyroidism, there is decreased TSH. Okay. So note this down. In primary hypothyroidism, there is increased TSH and T3, T4 levels are decreased. In primary hyperthyroidism, the TSH levels are decreased and T3, T4 levels are increased. Now let's talk about a secondary disorder. Okay, in primary disorder, the problem lies in the gland. Okay, in secondary disorder, the problem lies in the pituitary. Okay, so if there is a problem in the pituitary, okay, there is no TSH formed. That will lead to decreased T3 and T4. But remember, the thyroid gland here is absolutely fine. Okay, there is no abnormality in the thyroid gland. The thyroid gland is absolutely fine. So if we get even some amount of TSH, there will be adequate amount of T3 and T4. But that is not happening. Why? Because the pituitary is not able to form TSH at all. So this is secondary hypothyroidism. This is secondary hypothyroidism. Okay, now when we are talking about secondary hyperthyroidism, again there is a problem. Here is a secondary disorder. Again there is a problem in the pituitary. Okay, here there is increased TSH production by the pituitary, because of which the gland forms more and more amount of T3 and T4. Okay, so more and more amount of T3 and T4 are formed. So this is secondary hyperthyroidism. Okay, so we need to have a good understanding of this table, as it will help in diagnosing the patient if he has hypo, hyper, primary or secondary thyroid disorder. Now, let's take a look at the differences between hypo and hyperthyroidism. Okay, but before this, let's know what is the normal function of a thyroid gland. Okay, the basic function of a thyroid gland is to maintain the body metabolism. The basic function of thyroid gland is to maintain the body metabolism. If we have more thyroid hormone, there is increased metabolism, fast metabolism. If we have a less amount of thyroid hormone, there is slow metabolism or decreased metabolism. Okay. Also, thyroid hormone also plays an important role in thermoregulation. Thermoregulation, that is, it helps in maintaining the body temperature. The thyroid hormone helps in maintaining the body temperature. Now let's go on to the differences between hypo and hyperthyroidism. Now let us see the differences here. Okay, in hypothyroidism, as we know, there is decreased thyroid hormone. Okay, decreased thyroid hormone decreases the basal metabolic rate. Okay, and thus breaking down capacity of the body decreases. Okay, and this results in weight gain. Okay, as there is decreased basal metabolic rate, the body doesn't break down stuff easily. So this results in weight gain. Whereas in hyperthyroidism, in contrast, there is increased basal metabolic rate. Because of increased thyroxine hormone, there is increased basal metabolic rate. So there is faster breaking down of stuff in the body, and this results in weight loss. Okay, so hypothyroidism results in weight gain, hyperthyroidism results in weight loss. Next in the hypothyroidism, next is, as the body metabolism decreases, the temperature of the body also decreases. Body metabolism decreases, the body doesn't have much function to do, so the body gets cooled down. That is simple logic, right? So in hyperthyroidism, what happens? In hyperthyroidism, as the basal metabolic rate is high, the body temperature also automatically increases, because the body is doing much work to break down the stuff. Okay, so the temperature of the body also shoots up. Okay, in hypothyroidism, the patient has cold intolerance. The patient is intolerant to cold. Whereas in hyperthyroidism, the patient is intolerant to heat. Okay, in hypothyroidism, the heart rate and respiratory rate here is decreased, because there is decreased basal metabolic rate. Okay, because of the decreased basal metabolic rate in hypothyroidism, the heart rate and respiratory rate are decreased. Okay, whereas in hyperthyroidism, the heart rate and respiratory rate are increased because the basal metabolic rate is increased. Okay, in hypothyroidism again, also because of decreased basal metabolic rate, there isn't much of gastric motility. Okay, basal metabolic rate is decreased, gastric motility doesn't occur that fast, and this results in constipation. The patient suffers with constipation. Whereas in hyperthyroidism, there is fast metabolism. Fast metabolism means fast gastric motility. Gastric motility is more, so the patient can experience diarrhea in hyperthyroidism. It's just simple logic. It's all based on the basal metabolic rate. Okay, so also the females can encounter menstrual problems because of hypo and hyperthyroidism both. Okay, both have different sets of symptoms. Then let's take a look at the psychological aspect of this. Okay, psychological aspect of this, in hypothyroidism, the patient might end up lethargic. Okay, the patient becomes lazy. The patient's basal metabolic rate is decreased. The patient is lazy here, he becomes lethargic. In hyperthyroidism, there is psychosis seen. There is so much happening in the patient's body. There are feelings, there are different kind of feeling developed, so this results in patients ending up with psychosis. Okay, these are the symptoms associated with hypo and hyperthyroidism. Now let's talk about the etiology of hypo and hyperthyroidism. Let's see hypothyroidism first. The main cause of hypothyroidism is Hashimoto's disease. What is it? It is an autoimmune disorder where the thyroid follicles are destroyed. And thus T3 and T4 are not produced in sufficient quantities, resulting in hypothyroidism. Okay, it is an autoimmune disorder where the thyroid follicles are destroyed. Thus T3 and T4 are not produced in sufficient quantities, resulting in hypothyroidism. Okay, another cause is thyroidectomy. Okay, where the thyroid gland is removed either by subtotal thyroidectomy or complete thyroidectomy, resulting in decreased or no production of T3 or T4 at all. Okay. Also, another cause is drugs. Drugs like lithium, amiodarone also induce hypothyroidism. Here, a special note for amiodarone is a class 3 antiarrhythmic drug. Okay, amiodarone is a class 3 antiarrhythmic drug, and it may lead to either hypo or hyperthyroidism. Okay, let's talk about the etiology of hyperthyroidism now. In this, we are going to talk about Graves' disease. Okay, what is Graves' disease? It is also called as primary thyrotoxicosis. Okay, it is an autoimmune disorder where there are stimulatory antibodies against the TSH receptors, okay, which I just mentioned, which are present on the thyroid follicles. Okay, it is an autoimmune disorder where there are stimulatory antibodies, okay, antibodies formed in our own body against the TSH receptors which are present on the thyroid follicles. Okay, I'll tell you this in a simple way. Okay, there are thyroid follicles, okay, on which there are TSH receptors, okay, to which TSH binds and stimulates the production of T3 and T4. This is the normal physiology. But due to some changes in the body, there are autoantibodies formed in the body. Okay, there are autoantibodies formed in the body which stimulate the receptors, which stimulate the TSH receptors and increase the production of T3 and T4 dramatically. And because of this, there is sudden increase in the production. This results in swelling of the gland. Okay. The autoantibodies go and attach on the TSH receptors and thus increase the production of T3 and T4 dramatically. This results in increase in the production of thyroxine hormone. Thus, there is a swelling of the gland is seen. Okay. Other features which are seen in Graves' disease are exophthalmos, that is the eyeballs protruding out, and also there is pretibial myxedema. Pretibial myxedema is very important feature of Graves' disease. This is very commonly seen. Then next is all the visible eye signs are seen. Okay, all the visible eye signs are seen, such as the von Graff's sign, Dalrymple sign, Joffrey's sign, etc. Okay, there is diplopia, there is edema of the subconjunctiva. Okay, patient also experiences weight loss and is heat intolerant. Okay, the patient is intolerant to heat. Okay, also in Graves' disease, which is primary thyrotoxicosis, the CNS symptoms are prominent. And the CVS, the cardiovascular symptoms are cardiovascular symptoms such as palpitations, chest pain, ectopic heartbeats. These are not so pronounced. Okay, CVS symptoms are present, but these are very less. CNS symptoms are prominent. Okay, so this was about Graves' disease. Okay, so now what else can cause hyperthyroidism? That will be the iatrogenic cause. Okay, there is an iatrogenic cause where the patients without having complete knowledge, okay, about the thyroid hormone, the thyroid gland, start taking drugs, okay, for weight loss, because thyroxine increases the basal metabolic rate, causes weight loss. People start taking it, okay, without having complete knowledge about it. They start taking it for weight loss, and this might lead to hyperthyroidism. Now let's move on to the treatment aspect of this. Okay, we have to treat the patients who have hypo or hyperthyroidism both. Let's take a look at the treatment of hyperthyroidism first. Hyperthyroidism. Okay. First are the antithyroid drugs. Antithyroid drugs. What are those? First is carbamazole. Second is methimazole. And third is propyl thiouracil. These are the three antithyroid drugs which are generally used in the treatment of hyperthyroidism. Okay, but what drugs are to be used in treating a pregnant woman with hyperthyroidism? Suppose there is a pregnant woman with hyperthyroidism, only propyl thiouracil is used in this case. Okay, and also along with this, as we know that the basal metabolic rate is high, basal metabolic rate is high, this results in increased heart rate leading to tachyarrhythmias. Okay, for treatment of these tachyarrhythmias, we give beta blockers. Beta blockers like propanolol along with the antithyroid drugs are given for the patient in hyperthyroidism. Okay, let's come on to the treatment of hypothyroidism. Okay, replacement therapy by L-thyroxine, that is levothyroxine, is done. Okay, as the patient has decreased amount of thyroxine hormone, we are giving L-thyroxine to the patient, that is levothyroxine to the patient. Okay, as it is done as a replacement therapy. This will help in replenishing the decreased thyroxine stores in the body. Okay, this will help in replenishing the decreased thyroxine stores in the body. Okay, one last thing I want to share is about the myxedema coma. What is myxedema coma? It is the sudden deficiency of T3 and T4 levels in the body. Okay, it is the sudden deficiency of T3 and T4 levels in the body, because of which the patient ends up in a myxedema coma. Okay, it is an acute condition, develops in a short span of time, sudden deficiency of T3, T4 levels. It is an emergency condition. It is an emergency condition where we have to replace the thyroid hormones in patient as soon as possible. Again by the replacement therapy. Okay, emergency condition where we have to replace the thyroid hormones in the patient as soon as possible. Thank you.